we translate that mystery shopping tool, if you like, into the healthcare context. And now we're dealing with sensitive information and complexities that may be high risk. Then with regards to research on mystery shopping or medical mystery shopping, then we've got ethical considerations such as methodological rigor and ethical transparency. So like when I was doing my PhD, I started with the question of what is quality? And I was really surprised that, okay, it's hard to pin down. I ask you to think, what do you think quality is? Is it something good? Is it something outstanding? What's good enough? Now, post-World War II, Japan discovered Deming's principles, and that enabled manufacturing of tangible products, widgets, if you like. And what they did was they lowered the statistical variation in the production of whatever widgets and products. They did that very well. Okay, I'll get off track if I've got to bring myself back. Okay, so that was with products. Now, with services, we've got some added complexities. We've got credence qualities where you can't really sort of even evaluate what's gone on after the product has been or the service has been consumed. And sometimes these complexities involve, in the healthcare context, for example, multiple comorbidities. So then we've got the patient participating and co-constructing the quality of the patient, of the interaction along the way. So we ask the question, how do we measure service quality? And rather than doing a presentation on that, what I'm suggesting is that mystery shopping is an alternative tool. What we're talking about here is pseudo or fake patients presenting with fake symptoms and documenting or assessing the actual experience and the facilities as a review of service quality. And I've already mentioned historical application in retail, but there is some work in healthcare context. Jack Charles Collins and his associates did some work in 2017, 2018. They were looking at pharmacists' knowledge in this set of publications, essentially. And they did get consent to do this work. Some of them were bigger studies than others, and they in the 2017 work, they got all the individuals that were involved. They got that consent, but in the 2018, they added consent from the student pharmacists who were the pseudo patients. So that's interesting. Then more recently, we've got Angela Lim and her team. They looked at looking at the knowledge of prescribing antibiotics by the pharmacists, and their consent was opt-out consent. So an email was sent out with a notification that this work is going to go on, and the pharmacies that were targeted had 2 weeks to opt out. Then there's some other studies. Now, the last two slides that I've just shown you, they were Australian studies. These are outside of Australia and somewhat more controversial. Each of these did not get consent. They did have a waiver of consent by respective HRECs that approved, but these were more controversial. So the Rankin study, that was phoning up to see whether or not there was any disparities in people who had certain types of insurance, indicating ethnicities, for example. And they argued that the net weight, the net risks to the subjects outweighed the benefit of monitoring the healthcare access. Yeah. So Cho, Rowland et al., they They looked at this is a Chinese study, they looked at over-prescribing, and that's recognised as an issue, but they did a field experiment where they had a treatment group, and in the treatment group, they provided a notification that an anonymous shopper was going to come to their primary healthcare services. They had 96 clinics involved, and to them, the main ethical dilemma was that the pseudo patients were providing incorrect information, but some interesting ways of getting consent. They did something interesting with the feedback too. So they deliberately provided three different options to give feedback, to receive feedback on the on the mystery shop, right? They could receive the feedback publicly, and that was on the university website. They could receive it privately, and they could also opt for no feedback. Many of them did opt for no feedback. So we've got these different ways of going about the study. Collins et al., the last one on this slide here, that's actually Jack Charles Collins of the 2017 and the 2018 studies that I put on the previous slide. So they've published a critique of their own work and medical mystery shopping in general. So if we look at what is the advantages of these medical mystery shopping adventures, we've got authentic context observations, we're minimising the social desirability, we're supporting equity and inclusion. It's an excellent tool for staff development, but for me, the big advantage is that it's about the customer experience, and I see it as a tool to enhance that customer experience. But of course, there's some disadvantages. We've got limited scope because we've got, if you talk to this service provider on this day and that service provider on that day, then that's not really going to capture the full range of the customer experience and the operational variability. There's also potential for bias. So some mystery shoppers may interpret in a different way. There's cost implications if we're doing this commercially. And then there's employee morale concerns. So if it's not managed transparently, then that can not feel good for the people involved. And then, of course, the ethical considerations about covert observations, raising questions about informed consent and transparency. When we take that tool of mystery shopping and put it in the healthcare or the medical context, what we've got is a documented account of healthcare service experience from the patient perspective. We can look at whether protocols have been adhered to. We can analyse the dialogue and the communications that took place, and we can identify whether or not the outcomes were appropriate. This can reveal practice gaps. It can reveal the need for frontline training. It can give us observation of behaviour in situ. And like I've emphasised, it's a depiction of quality from the patient perspective. Ethically, we've got informed consent concerns. We've got potential for deception, so use of disguised identities and scripted interactions. There's a risk of harm or distress. Staff may feel surveilled or penalised. And there's sensitivities, contextual sensitivities required in culturally diverse or marginalised settings that covert observation may exasperate, given historical happenings. And then limited generalisability. So core issues, as we've heard much talk about yesterday and today, Section 2.3.10 is what we need to comply with, and we want to protect as best as we can. We can go for being transparent with the providers up front, or we can go with requesting a waiver. The work that I've talked about today, if we go back here, So this work in Australia and this work in Australia, all of that used consent. And what I admire about what Collins and the teams did is that they used an immediate coaching feedback mechanism. That was not the case with these three studies at the top there. They used waivers, and the critiques of those studies are high. I think that, how am I going for time? I'm not sure where I'm at on time.
Yep, just under 2 minutes left.
Oh, excellent. Thank you. All right. So the practical implications of this is that we want to use it selectively, and we want to use it ethically. So is deception okay? Well, if we've got consent from the organisations, the hospital system, in my case in America, we can get that level of consent. We can have a next level of consent where we go to the actual specialists involved. And then there's the individuals. Do we want consent from those particular individuals? And when the consent is provided by the organisation as an umbrella consent, that organisation can choose to go to the specialist outlets or clinics that are involved and speak to the individuals directly to say, hey, this is going to happen. If you don't want to be involved, it's okay, let us know and we'll see what we can do, right? So we can enable the consent in an ethical manner. When a waiver of consent is requested, of course, we have to meet that criteria that both Andrea and Gordon have been talking about for 2.3.10. But what I say is that the ethics review is valuable to the process, right? So if there's a dialogue between the HREC and the researchers, or this is what we're trying to do here, and this is how we could do it, and then negotiate what's the best way forward here. I think that that's really useful to the validity of the work, to the protection of the people involved, and the outcome at the end of the day. So we want to minimise the deception with robust debriefing where possible, and we want to combine it with immediate feedback and coaching to support the change going forward. When we're reporting, we want to report aggregated, de-identified results to protect privacy. And even, I mean, that's such a common point to hear, report aggregated, de-identified results. But like with Charles Collins' works, for example, in 2017 and 2018, they were targeting pharmacists in Sydney. And if in reporting the results, they said X pseudo patient presented at this pharmacy at this time, we know who the pharmacist is on duty that day at that time. So being very careful about how report the de-identified results are put out there. We want to protect at all costs. And there you go. That's it.
Sharon, thanks very much for that. I think it raises some interesting questions around the use of this mystery shopper approach in research. I am conscious of time. There is one question in the Q&A that you may want to have a look at it and provide some feedback on if you wouldn't mind. But I'd love to move on to our next presenters, or our next team of presenters.